like to introduce our distinguished speaker, Lord Turnberg, Professor of Medicine and member of the House of Lords. Lord Turnberg was born Leslie Arnold Turnberg in Salford. He studied medicine at Manchester University, the first of his family to be a doctor and the first to go to university. He worked in what is now the Salford Royal Hospital. He became Professor of Medicine and Dean of the Faculty of Medicine at the University of Manchester. In 1992, he was elected President of the Royal College of Physicians in London. 2 years later, he was knighted for his services to medicine. And in 2000, he was given a peerage and a seat in the House of Lords. He is the Honorary Fellow of 16 United Kingdom and overseas colleges and faculties. We are very privileged to have the opportunity to hear him speak today. And the title of his lecture is a subject of enormous interest to all of us at iu3a, is Patients First, How to Save the NHS. Lord Turnberg. And he will speak to us now.
Thank you very much indeed for that very kind, embarrassing introduction. I hope I can live up to it. The topic, Patients First. I've been involved in the National Health Service, as you've heard, for 50 or more years, and it is in trouble. I suspect that some of you, one or two of you, may have had close encounters with the health service of late. I certainly have. And it is interesting that experiences vary enormously. Some people have very good experiences with an NHS and get very good service. I, for one, am very grateful to the sort of services that I've had. But then you hear stories of terrible problems. You hear stories of people hanging around in the accident and emergency departments for hours and hours, perhaps days, not getting into the hospital. You hear of people not getting an appointment with their general practitioner, waiting forever to get through, and even when they get through, their appointments are in a few weeks' time. So the whole thing seems to be riddled with problems of that type. So it's not much wonder that the newspapers are full of reports of disasters. They rarely report the good experiences of patients in the NHS, but they do report the bad, and there's an awful lot of it. I remember when I first started in healthcare in the 1950s, I was a junior doctor, and people used to come in and say, morale has never been lower. So that has been a constant theme throughout my life. And certainly now, within the health service, morale has never been lower. And I think it is even lower than when I first started in the NHS. So there are lots of problems, there are lots of difficulties. And in the book I've got here, which you can purchase if you're not turned off by my talk, the problems now do require a new look. I'm not one of those who believe that the health service should be thrown up in the air and we should start again. We should reorganize the whole thing, perhaps develop this as a German or French insurance model. I'm not one of those. I think we've had far too many reorganizations and disorganizations. Every 2 or 3 years, a new health minister has come along and decided that we need a new reorganization of the way the health services are administered. And they throw all the layers of the administration of the health service into the air, and they come down in a different organization, and nothing much happens to the patients. The patients are the last people to be considered in these reorganizations. And there are reasons behind them, are very varied. We've had an introduction of the market, the internal market, into the health service in Margaret Thatcher's time. We've had people, health ministers, reorganising and trying to make markets fitter for purpose, internal markets. And now we've thrown them all out because they've realised that competition, which was the main feature of these markets, is no longer suitable. We've got to have coordination and integration. So integration is the buzzword, not that we see much of it, but the buzzword is now integration, not competition. So we're in that position at the moment. We will see if the new Labour government manages to integrate the care that we need, because I think that's what we do need. We do not need a complete reorganisation and a new funding model. A lot of people seem to be saying that we do. I don't. So let's look at the problems, and I believe that we should start in the community. A lot of people talk about waiting lists and waits in A&E departments, but I think we do need to think about what's happening in the community. And it's there where community services, social care and primary care are the keys. If we get social care right, if we get people being cared for in the community, in care homes right, then there won't be a need for them to stay in hospital. You know that 15% of all hospital beds at the moment are filled with patients who don't need to be there, who would be much better off at home or in a care home. 15% of beds, that would relieve an awful lot of problems in the hospital services. It would reduce the number of patients waiting in A&E departments for a bed, reduce the number of queues outside, of ambulances outside the hospitals, and it would relieve those poor people who are having to stay in hospital unnecessarily. But we do have to have access to care homes. Now, what is the problem with the care homes? There are three problems which I think we can improve. It may need a bit of money, but not much. Remember that care homes are funded by local authorities. Care in the community is local authority funded, not National Health Service funded. The big mistake in 1948, let me go back historically, big mistake in 1948 was to have three different funding systems for health. National Health Service for hospital care, local authority funding for social care, and primary care was independent practitioners contracted with the NHS. Three different systems of funding, and they don't work very well together. That is a big problem. However, we are where we are, and it is social care funded by local authorities that's been under this terrible pressure for a very long time. It now is, I don't know, 25, 30% underfunded compared to 5, 10 years ago. So the Tory government didn't do much for that, and I'm not sure yet whether the Labour government is going to improve it. It really does need improving. They are right at the bottom of the funding ladder. And it's clear that social care, which accounts for the biggest proportion of local authority funding, is underfunded. This means that they pay care homes at the minimum rate. Care homes, you know, are not owned by anyone but private companies. Care homes are owned 90% by private companies, some of whom are going into bankruptcy because they can barely afford to keep going. Others are making a bit of profit, but they are on the edge. They charge local authorities £900 a week to look after someone in them, a patient needing care. £900 a week barely covers what they need. And that £900 is actually underfunded. That is, local authorities often pay much less. They rely very heavily, these care homes, they rely very heavily on people paying privately. Okay, now, the problem is that the workers, there are three problems in care homes: workers, funding, and the third one I'll come to in a moment or two. The workers, first of all, the care workers, these are right at the bottom of the scale. They are the least well paid of people in healthcare. They have minimum wages, many of them are on 0 hours contracts, and they're a very unhappy set of staff. They have no nationally recognized qualification. They have no nationally recognized training program. They're not registered by any health registration body. They're just free. And they don't have any career structure. Someone who's been a care worker in a care home for 5 years gets 10p an hour more than someone who's just started. It's a crazy system. Not much wonder that many leave within the first 12 months, and that there's a high 150,000 gap in employment. There's a loss of staff and many vacancies. So that whole area does need attention. My proposal, for what it's worth, is give them a nationally recognized training program, registered qualification, and a career structure. That's what they need, that's what they deserve. These are vitally important care people. And if we improve that, the care homes would manage much better. But we need the money to pay a career structure so they can go up the scale. Some of them could go on to the nursing assistant grade in nursing. If they had that structure, that would make a much more attractive career. And I think if we did that, care homes would be much more effective. The second thing about care in care homes is that if you are someone in the community and you wish to go into a care home because you can't manage at home, you haven't got relatives nearby to help you, you need to go into a care home, the bureaucracy involved, and I don't know whether any of you have tried this, to get into a care home is incredible. It requires 2 sets of assessments. One, whether you've got the right need. Are you ill enough or incapacitated enough to go in? And B, do you have enough money to support yourself? Those are the 2 criteria. Now, you have to have 2 sets of assessments in series, not at the same time, and it can take months. There's a waiting list. That's one thing. Secondly, if you have assets worth more than £23,500, £23,500, that includes your house. There are not many houses worth less than that. But if you have any assets worth more than £23,500, you pay for yourself. So it makes it extremely difficult. Many have to sell their house to go into a care home. Now, there have been assessments of whether it's going to be possible to up that limit to £100,000 or £50,000, but the government has turned that down. It's not been possible. The last government turned it down. This government's thinking about it, but it would cost some money, of course, because then the burden on the individual would be less, but the burden on the taxpayer would be more. So there is an issue there, but it's something that we have to look at. The third area, which I want to talk about briefly, is the fact that if you have someone at home who's disabled or elderly and needing care, and a relative, a daughter, a son, a wife, husband, is willing to look after them and stop working in order to do so, they're entitled to a grant from the government if they can prove that they're A, full-time, looking after the relative, and B, not able to work at all. As soon as they're able to work at all, then the money they get is less. It was £75 a week which if you stop working, £75 a week doesn't actually get you very far. It's gone up recently, I think it's gone into the 80s. I'm not quite sure of the figure, but it's not a lot. So that means that people, and there are millions of those people looking after their relatives. 5 million, they say. So it's saving the country an enormous amount of money. And yet we are taking advantage of this available workforce for which we're unwilling to pay very much. Those are three things which we do need to satisfy if we are to get patients in the community helped and patients in hospital who shouldn't be there helped. Okay, so that's social care and community care. Incidentally, we've lost our health visitors. We don't have many of those. Meals on Wheels seems to have disappeared. I don't know whether any of you have had access to any of these for any of your relatives. Then you must know how bureaucratic and how difficult it is to get that sort of support. I have to say, some people in some parts of the country do get good support, and I know of examples of that. But if you live in Hull or Grimsby, where your need is greatest because health is worse there, mortality rates are higher, the number of doctors, the number of health visitors, the number of healthcare workers is low. So the demand is high and the availability of resources is low. So if you live there, your chances of getting any sort of support is limited. If you live in, I don't know, Westminster, you get a better chance. And maybe if you live in Islington too, I don't know. So it is variable, but there is an enormous discrepancy around the country. That's as far as I can get in social care. Let me just talk a bit about primary care. Overall, patients are very unhappy with the level of care that they get from their general practitioners. Overall, I have to say my own GP and my own GP practice in Belsize Park is excellent. I couldn't complain. And there are lots of very good GPs doing very good work in difficult times. But unfortunately, far too many are not. And they're not capable of doing it because they're stretched beyond capacity. The number of patient consultations, the number of patients wanting to go to GPs has gone up quite markedly. The number of GPs has risen, the number of full-time GPs has risen, but nowhere near to keep track with the number of patients. So the workload has increased enormously. Secondly, they are distracted by administrative work. They're distracted by organizational work, sitting on committees, so many committees. It's a ridiculous situation. So their ability to work clinically, seeing patients, is limited too. So the numbers are down, availability of time is down, and they're stretched beyond their capacity. Let me just read to you what one GP told the House of Lords Select Committee. A GP told the Select Committee, Common Select Committee, I have a list on my toolbar with all the blood results that have come in from all the patients, letters that have come in from consultants, discharge letters, and anyone else who wants to write to us, which all has to be looked at and put into the patient record. There are other things like insurance reports, DVLA reports, that sort of thing, prescriptions. It's 60 to 100 a day. Blood results, again, 60 to 100 a day. Letters, it's 20 to 30 today. Maybe 2 or 3 reports a week. That sort of distracting work does not allow them to get on with what everyone else, what their patients want, and what in fact they want to do. So it is extremely difficult. Lots of solutions have been suggested, some of which are helpful. One is let's put GPs together in bigger groups, in polyclinics as they used to be called. They stopped calling them polyclinics, it sounded like the communist regime, so they stopped calling them polyclinics, they call them something else now. But it meant bringing GPs together into larger groupings, and there is one up the road, I believe, in Kentish Town anyway, where they have lots of GPs, X-ray facilities, breast cancer screening, all those sorts of things, which seems to work well to an extent. The problem is you can't put them everywhere because in the countryside you can't have it. You've got to have a big population to do it. And continuity of care, your GP, your patient, is diminished by this clinic idea. It works quite well if you have a patient with an acute problem. They've broken a leg, or they've twisted their arm, or they've got a bad cough and cold, and you're just one-off. A GP who's well trained will deal with you nicely. If you've got a chronic condition requiring repeated attendance, and you see a different doctor each time, that's not quite so good. Continuity of care is important, very important. There's a comparison made between Britain and Norway, where in Norway, patients see the same doctor each time, and their mortality and morbidity rates are much better than ours. The only problem is that the reason for that is that they have 1,320 patients per GP. We have 2,500 patients per GP. So the workload is entirely different. It shows that if you do reduce the number of patients per GP, you can, in fact, have continuity of care. So there are big problems in general practice. It means that patients can't get through to them. Some patients can't get through to their GP. Some are then told to phone 111 or turn up at their accident and emergency department. And if they dial 111, they may or may not get a satisfactory answer, and if it sounds significant, then be on the cautious side. 111 reporter will say, turn up at your A&E department. And that's why accident and emergency departments are often filled with patients who really shouldn't be there. They should be at home and treated by their GP. And they make the work of accident and emergency departments even more difficult than they should be. So we do need to improve general practice. We need the numbers. We certainly need more GPs. The workload is such that they need to have their numbers increased. There are plans to try and recruit more GPs, but we are losing them quicker than we're recruiting them. They're off to New Zealand and Australia, and we do have to retain them. And we retain them by making general practice more attractive, making GPs feel that they are needed and not reviled. And I think that is very critical. We do need to ensure that they are not overwhelmed by administrative tasks and by committees. We must cut this business of them being on all these committees that are administering the service. We need managers for that. We must make sure that they can do the job they are trained for. We need more administrative assistance in primary care. At the moment, they have difficulty employing such people because they're expensive and their income often doesn't cover it sufficiently. We hear talk of GPs earning a fortune. They don't earn a fortune. They earn a reasonable salary, but they have to pay a lot out from that in order to maintain their practice, particularly if they're self-employed. So we need more of them, we need to recruit more, we need to retain more, and we need to ensure that they are supported fully by administrative workers. Those are my tentative solutions. These solutions are not novel. For heaven's sake, we've known about them forever. It's not a new suggestion. It came out in that report from the House of Commons Select Committee. Okay, so that's where we have to focus. Social care and primary care. And we can do it. I'm hoping West Streeting will pay attention to that. He has a copy of my book, whether he's read it. Okay, what about the National Health Service, about hospital care? If you're looking for a set of caring staff, nurses, doctors, porters, radiographers, who are happy, contented, and engaged in their work full-heartedly, it's not in the NHS. They are the most unhappy, the most disillusioned, most disaffected set of staff you could wish to meet. And yet, if you go into a hospital and you're in the hospital or you're having a test in the hospital, the way they treat you is very good. They're very kind overall. They're badly treated, incidentally. There are these notices all over the hospitals now saying, don't treat your carer badly, they're doing their best, this sort of thing. It won't be tolerated if you hit your nurse. So there is a lot of that, but they do feel threatened because patients are often unhappy and they feel threatened that they're going to be abused in one way or another. And they feel disillusioned. Lots of reasons. Let me talk about the nurses first, and what we should be doing for the nursing staff. I have a lot of personal reasons for admiring the nursing staff. They have treated me very well indeed over the years, as I'm sure they have for you. The problem there is that they go through a university education to become a nurse. When they have graduated, they have high aspirations of doing a good job, and they do a very good job. They're very well trained, very knowledgeable, very educated. They go into looking after a ward, and they immediately get promoted to staff nursing, nursing sister, or charge nurse. But they don't stay there. That job is just one step on a ladder leading off the ward and away from clinical care. They are there for 2 years, 3 years maybe, and then they're off to higher things, teaching, education, management, and perhaps into one of the specialty services. So you have nurse specialists in cardiology, gastroenterology, neurology, chemotherapy, and they're very well trained and they're very good. But we've lost the nurses at the ward level. We've lost a senior person in charge of a ward. In the old days, my old days, we used to have a nursing sister who was a mature, usually a woman, who was authoritative and strong, and everyone, the doctors included, ran scared of her. And she ran the ward like a battleship. She was caricaturing, of course, but that's really the figure of the word nursing sister on the ward. And all the patients were in their ward, were in their beds with the clothes neatly over them. And she would know every patient, she would know what was happening to them all, and when you went on a ward round as a doctor, she would say, this patient has not been well in the night, and she would have everything before you. So that was very good. We don't have that now. The nursing sister is no longer there long enough to develop this sort of authority. She's moved on to bigger and better things. That's not very good for nursing care on the wards. I don't know how many of you have had to be an inpatient patient recently, but there's a bewildering series of nursing, and I'll come to the doctors in a moment, bewildering series of nurses coming through on different shifts, different rotas, and you never seem to have the same nurse, and you rarely see the nurse in charge of the ward. That's not very good. We do need to change that. My recommendation is to make the nursing sister in charge of a ward a permanent career structure, career post. That should be the aim of some of the nurses coming through the system. And in order to make that post an attractive one and to make nurses want to stay in it, we have to give them the authority, the career structure, and the relevant pay structure to go with it. Their pay stops at the nursing sister level, and it only rises when they go off the ward. You've got to start giving them the right level of pay in the ward. And that's my solution. I did once say, I've said it a couple of times now in the Lords, in debates, that we should give nursing sisters the same salary as a consultant physician, because that's the importance of the job. And consultant physicians don't go on having been made a consultant at the age of 34 or 5. They stay in that post. The same should be for the nursing sister. So pay them the right rate, keep them there, and let them be able to oversee the patients in their care. That's one thing. Then we have the other end of the spectrum. We have a problem that the nursing profession and the health service created when they made nursing a university graduate scheme. They lost a section of nursing called state-enrolled nurses, SENs, who didn't have to go through a full graduate program. They came through a practical nursing program which gave them sufficient training to look after patients, be able to feed them, nurse them, bathe them, take them to the toilet, look after them on the ward, make sure that they had a person-to-person contact. We lost that. Only recently have they started coming back in another guise as associate nurses and assistant nurses. It's not a very attractive job, unfortunately. We've not filled enough posts. But we need them at that level. We need patients need people who are not necessarily university graduates. I have nothing against the nursing graduates. They do a fantastic job. They're very good. They're as empathetic as anyone. But they don't stay. They're busy looking at the next stage of their career. We need people at that level. We could feed into that if we gave the care workers in care homes the capacity to migrate up into the associate and assistant nursing grade. So there's a number of ways we could deal with the nurses. What about the doctors? Well, I used to be a consultant physician, so I'm speaking from some experience, but my experience is from the 1980s. So it's a long time ago. In those days we used to have a team. We used to have a group of doctors that worked closely together, consultants, maybe more than one, trainee staff, nurse, perhaps a nursing sister, meeting to talk about the patients and to go on a ward round. It was a very good team. Everyone in the team, including, in my case, dietitians, as well as nurses, knew everything about every patient. And when we got to the bedside, we knew what we were talking about, and the patients knew that we knew. And that gave a lot of confidence. We don't have that now. The ward round seems to have disappeared. The team seems to have disappeared. The consultant comes in and does not necessarily have a nurse to go around with him or her. In fact, over 50% are now female. They don't have a nurse to go with them. And if they did, they don't know where to find one that knows the patients. That's a terribly fragmented and fractured system. The trainees are there in a rota which takes them in for a 3 or 4 month period and then out. And they have very limited hours. They have this 48-hour limit on the hours that they can work. So there's a constant pressure to move on, to change, to rotate. So continuity in hospital care is limited. We've got to get a grip on that. That's got to be got a grip on. We have to make sure that doctors and nurses have food at night. You know that most cafeterias, canteens close at 6 in hospitals. So if you're a doctor on at night, or a nurse on at night, you have to go to one of these slot machines and get a sandwich or a drink out of it, or send out for a pizza. It's not ideal. They're not looked after, and they know they're not looked after. They don't have car parking, have to pay a car parking fee. The doctors and nurses are not supported in the system, and they feel it, and they know it, and they feel disregarded. We have to get back. And the way to do that is to ensure that the doctors themselves, the consultants themselves, get a grip. I keep pushing this on the colleges. We have to get back to the system where the consultant staff can meet regularly. They don't meet regularly because they're constantly being pushed. Many of them go off into private practice where they have a much easier life. We should be bringing them back. They need to meet regularly in clinical staff meetings. They need to have regular ward rounds. They can bring back a ward round. They could bring back their team if they can find them. And they must insist on taking the nurse, the sister, with them on the ward. And they must have a regular time. I'm not entirely sure why they don't do it. They say that the management arrangements don't allow them to do it. And I think that is a dampener on the system. But we have to try, we have to get back to that. I'm told that, I don't know much about how surgeons operate, but I was told by a group of surgeons I spoke to recently that they're told that they've got 1 operating session a week. This is the date, this is the time, and we can't provide you with any more space. And yet there are waiting lists. What on earth is that about? That the management insists on the number of sessions surgeons can operate. That has to change. That has to change. So, I talk in the book about problems in mental health services, which are pretty bad, and in maternity service, which is pretty bad. But I won't have time for that today. I talk about problems in public health. I was involved in the public health laboratory service as chairman of the board, but I resigned because one of the governments that was in charge at the time, I'm sorry to say it was the Labour government, decided to dismantle it very badly. And it meant that this service, which is supposed to protect the public against infectious diseases, was ill prepared for the COVID epidemic. It would have been much better prepared if it had stayed as it was when I was involved. So I talk about public health, talk about medical research, and anything else to deal with patients in a relatively short, small book. So I hope I've covered a reasonable range of things. I'm happy to answer questions, and anything goes.
That was a superb talk and of a huge interest to all of us. Before I open it up to the floor, I would just like to ask one question. Is Wes Streeting listening to you?
Well, he listens, whether he takes any notice is another matter. I've spoken to him, and he and his team have seen the book, but they've got a lot of things on their mind, particularly the lack of money.
Okay, who wants to ask a question? Lady in the pink jumper there. No, sorry, it's over there.
Back here.
After that, you can have it.
My concerns are, thank you very much for saying that's why I've been
Mine's not on. Sorry, that's my fault. It's not on.
Where's your turn?
At the bottom.
At the bottom.
Just press it.
Can you hear me now?
Yeah.
Okay, I am an ex-nurse, my name's Anne, and thank you very much for saying that we do actually need to reward the nurses at the bedside in terms of introducing the equivalent of a consultant role. The other two things I would like to express concern about, you talk about the enrolled nurse programme. They were a very frustrated group of person. I was a nurse educator as well. They always felt that they were seen as the second best to the staff nurse.
Yeah.
And while I agree we do actually need a nurse at the bedside, not a healthcare assistant, that might be controversial, what we need is an articulate, research-based knowledge nurse who can argue, or he can argue the case for the best care possible. We do not need somebody at the bedside who does not understand how the body works, how research works, and cannot articulate their concerns. Also, one thing I have, last question, sorry, you didn't mention care in the community at the patient's home, and I'm just wondering, do you cover that in your book? The dire state of that as well?
Yeah, I do talk about that. As far as I agree entirely that the state enrolled nurse was not a very happy position because they regarded themselves as the lowest of the low. We have to improve their morale, we have to improve their standing and their education. But how does one retain them at that level on looking after patients? And I think this is a difficult balance to take. How do you get people willing to bathe patients, do all the necessary nursing care, and maintain a reasonable position in the hierarchy?
Money.
Okay.
Money, yeah, well, you've got to pay them, certainly. The other question related to...
This person in the pink.
There was a second question.
Home visits from doctors.
Oh, the care in the community. I did speak a little about that. Care in the community is diminished. It relies very heavily on volunteer relatives, and we don't fund them, we don't reward them, we don't consider these care in the community people. And we don't have enough health visitors. There's hardly any. So we've got to repair that.
Thank you. Margaret, there's a person in the fourth row over here. You still haven't answered the question, I'm so sorry. Okay, I'm so sorry.
My first job was as a dietitian in an American hospital, and that was a long time ago, and it was the first time that I was observing physician assistants, which I thought was an amazingly good system, and why was that not the case in the NHS? Now, PAs have now been introduced, but I've heard that they are not welcomed, not supported. In fact, the medical staff, more than anyone else, hassle them, critique them, undermine them. And I'm just quite confused because when I observed it in the American hospital, I just thought it was the most logical, most helpful, the most cost-effective way. And it stopped every doctor having to spend hours and hours and hours with a slightly coughing person. They were triaged. So what's your view on physician assistants?
Yeah, I'm going to get myself into trouble now with that. Because I agree with you. I think physician associates are valuable members of the team. They've been around in one form or another for over 20 years. It was when they were described as physician associates that people got hot under the collar, because it was the word physician that sounded as if they were fully qualified. And the arguments that were laid by the BNA and by the College of Physicians was that they are not physicians, they're not safe. They can't prescribe, and they have to consult the next person in line before they can actually do anything. I think if we stopped calling them physician associates and calling them doctor assistants or something of that sort, medical helps, I think we would get round it, because undoubtedly my experience of them is that they're very helpful to the service. So I'm a bit out of step with some members of my profession, but I do believe that they're a valuable member within the limits that we prescribe for them. The GMC have prescribed limits to what they can do, and I think within those limits they're very helpful. I'm all for them. Terrible.
There's someone here in the front.
Thank you very much for a very interesting talk, and I agree with many of your solutions. Certainly more training and better funding for, well, most things. The trouble is that better funding means more taxes. How do you propose to, or do you address that issue in your book?
I do actually, yes, very tentatively. There is certainly a need for more money. I think the Labour Party made a big mistake in saying they weren't going to raise taxes. When they put themselves up for elections. They would have won. The Tories were going to lose whatever they did. And they would have got in and would have been able to raise taxes generally. I think this winter fuel nonsense was a big mistake. They should have just put 2p on everyone's income tax. Forgive me. However, we are where we are. And one of the things I suggest, I'm not alone in suggesting, the idea of a hypothecating tax. We do have a national insurance, we pay national insurance. National insurance payments just go into the general taxation. We don't know what happens to it, but it goes out to pay for benefits, the health service and many other things. But we don't know how much goes into the needs of healthcare and social care. The problem is, I would suggest that we have a national insurance payments going into specifically the health service and